एवरीवन वेलकम बैक टू माय यूट्यूब चैनल। यहाँ पर हम जो है बात करने वाले हैं इस वक्त वो टॉपिक है जो है इम्पोर्टेंस ऑफ बेसलाइन रिस्क इन जनरल इवन द बेस्ट इंटरवेंशन दोज विद द लार्ज रिलेटिव रिस्क रिडक्शन will produce small absolute risk reduction only with the risk of the event in control group patient. The baseline risk is low. Perhaps this is intuitively obvious. If few people are likely to experience the event, it is not possible to prevent it very often. There are two very practical implications. First, even the best interventions are unlikely to produce the clinical worthwhile effect if the event that is to be prevented is unlikely. Here is the topic of discussion is that if the event is unlikely, then whatever intervention is used is not take any good advantage because the event is unlikely. The converse of this is that an intervention is more likely to be clinical worthwhile when it reduces the risk of high risk event. For example, we can say that if a patient come to the PT with a topic with a problem which is not concerned with PT domain, it will concern toward the physician, orthopedic, or any other. Then if a PT come with that issue and the patient come with that issue, the PT cannot cure her or him without by using every intervention because the treatment is out of his or her domain and diagnosis is wrong. Second, as a magnitude of the effect of the intervention is likely to depend very much of the risk to which untreated participants are exposed. Care is needed when applying the result of a clinical trial to a particular patient if the risk to the patient in the trial differs markedly from the risk in the patient in the trial differ markedly from the risk in the patient from whom the is being considered. If the risk is in control participant in the trial is much higher than in the patient in the question, the effect of the intervention will tend to be overestimated. That is, the absolute risk reduction calculated from the trial data will be too high and the number needed to treat will be very low. There is a simple work around that make it possible to apply the result of a clinical trial to the patient with higher or lower level of the risk. This approach described here is based on the method used by Strasser and Sackers 1999, MC Lister et al. 2000. The absolute risk reduction or the number needed to treat is calculated as described above directly from the results of the trial, but it is then adjusted by a factor let's call ITF, which describe how much work risk participants are at more than untreated control participant in the trial. A value of greater than 1 is used when the participant to whom the result is to be applied are at a greater risk than control participant in the trial, and a value of less than 1 is used when the patient to whom the result is to applied are at lower risk. The untreated participant in the trial. The absolute risk reduction is adjusted by multiplying the and number needed to treat the adjusted by dividing B by F. Following example illustrate how this approach might be used. Physiotherapy treating a morbidity obese patient undergoing major abdominal surgery might estimate that the patient was at risk of respiratory complication at the participants in the trial of the OCL in 1997. To obtain a reasonable estimate of the effect of this is to take into account the greater baseline risk in the participant than in the participant in the trial. The number needed to treat, which were previously calculated as 5, could be divided by 2. This gives a number needed to treat of 2.0, which round about 3 for morbidity obese participant. Thus, we can anticipate an average larger of the prophylactically therapy among high-risk patients. This approach can be used to adjust the estimate of the likely effect of the intervention for any individual patient up or down on the basis of the therapy perception of their patient risks. Regarding that, any query you can ask me in comment section. Thank you so much.